Hi, I'm Dr. Emma New. I'm a psychiatric trainee in Oxford. This is the Warnford, which is the hospital where I do most of my work. It's part of Oxford Health NHS Foundation Trust, but I also do on-call shifts at the John Radcliffe Hospital, which is sort of the main physical health hospital in Oxford, and also where we have our A&E department, which is where we see most of our psychiatric emergencies, which is what I'm going to be talking to you about today. So I work for a service there called the Emergency Department Psychiatric Service, which we abbreviate to EDPS. And just to give you a warning, in this talk, I'm going to be talking about quite a lot of potentially triggering and traumatic things such as suicide, self-harm, depression, mental illness, just to give you a heads up. I'm also going to undergo a costume change partway through because there was a bit of an issue with the recording for this. So I'm actually recording the first bit slightly later than the second bit, just because there was an issue with the recording. So yeah, let's kick off. So patients come to us in the emergency department either from they just walk in, so they've been feeling really bad at home and they think it's safer to be with us. Sometimes they're redirected by their GP. Sometimes, although less commonly, they're brought by the police. And yeah, just again to reiterate, I'm going to talk about some quite difficult topics. So the kinds of things that we see in EDPS, attempted suicide is probably the most common, alongside self-harm, and often it can be quite difficult to differentiate between those two, because sometimes patients will feel that something that we know is far less dangerous and less likely to cause death. To them, you know, something like taking 8 paracetamol tablets, they thought that was enough to kill them. So it can be quite hard to disentangle, was this an attempted suicide or was this self-harm? And I'll talk about that later, about how to ask those really difficult questions. Self-harm used to be called DSH, deliberate self-harm. We've sort of moved away from that terminology now because there's quite a lot of stigma attached to it. I'm also going to talk about agitated patients that we're often asked to see by the A&E clinicians. And there can be a multitude of reasons behind the agitation. Obviously, there are medical causes, sort of more tied into the delirium side of things, which I'm going to talk about a bit later. But we also see psychosis, and that might be somebody who this is their first presentation of psychosis. It might have been triggered, for example, by an intoxication or you know, taking weed for the first time, something like that. Or it could be somebody who's well known to us and they're just having a relapse for some reason, either because they've decided to stop their medication or because a stressful life event has occurred. And also, much more rarely, we sometimes get asked to see dementia patients, but I was specifically asked in this lecture to talk a little bit about how to differentiate between delirium and dementia, so I'm going to talk a little bit about that as well. It's not something we see so much in the emergency department, but it is something that we're often asked by the medics to help out with sometimes. So, the most common presentation is, like I said, attempted suicide and self-harm. Interestingly, the demographic of those who attempt suicide or commit self-harm is very similar in Palestine and the UK, and there's quite an interesting paper by the Bar about that from 2012. So what I mean by similar demographic is that more men than women complete suicide, but more women tend to attempt suicide. There's also a skewing of older patients tend to be those who complete, but younger patients tend to make more attempts than older patients. Now, obviously, looking at that pattern, there's a lot more behind that, and the stories patients will have will be completely different from one country to another. There will be completely different reasons for them feeling the way they do in one country to another, and you know, I'm fully aware that there's far more traumatic experiences, you know, being experienced by people living in war zones than the patients I see in Oxford, who are often from quite privileged backgrounds. The other thing just to mention is that, generally speaking, women experience more suicidal ideation than men. That's just a pattern that we tend to see. And it's something that sometimes it can be helpful to try and normalize with patients, especially those with depression. It can be really distressing to have intrusive thoughts of self-harm and suicide, and it can be quite reassuring to some people that actually this is part of your depression. This is part of your illness. It's not that you're going mad, I guess, for want of a better phrase. So there are lots of risk factors for suicide, and risk assessment for suicide is not great. There is no point saying someone is low, medium, or high risk for suicide. People have tried doing that, and it is of zero value. However, there are some red flags for things to just think about if you're seeing a patient, when you're thinking, how safe is this person to go home by themselves, for example. So we know, like I said, men are more at risk than women, and that typically the very young and the older people are those at risk. So if you're seeing a man over 45, you're probably a little bit more worried about him actually completing suicide than you might be if you were seeing a 21-year-old lady. A history of depression, previous attempts obviously increase someone's risk. Excessive use of alcohol or other drugs. Loss of rational thinking, so that could either be psychosis or a dementia. And the other thing I think is worth highlighting here is there is a period of sort of good insight in psychotic illnesses and in dementia where people are at increased risk. So for a dementia patient, that's usually very early on in the course of the illness, where they can see they are heading towards a life of living with dementia, and at that point people are at a much more increased risk of suicide. And again, with psychosis, again, it's either often early or it is as their psychosis is getting better. So I suppose the typical example might be after somebody's first psychotic episode or after their manic episode, they develop insight into what they did or what they said during that episode, and it may have lost them friends, or they may have assaulted a family member, for example, and it's the realization, oh my goodness, what have I done? That was so out of character. That can predispose them to depression and indeed to risk of harming themselves and taking their own life. Being single, widowed, or divorced, we know increases your risk of completing suicide. And having an organized plan. Now, what I mean by that is, did they have a very specific plan? Did they know precisely which train it was, at what time, on which platform they were planning to jump in front of? Did they leave a note? Did they make sure nobody would intervene? Were they, for example, in a locked room? Things like that. Did they prepare a will beforehand? All of those things are worrying signs. And it's much more reassuring if you see a patient who impulsively grabbed a load of tablets and took them all at once, having not planned anything. That suggests that they're slightly lower risk. Again, lack of social support kind of ties in with marital status. And if a patient tells you that they're planning to kill themselves, obviously that is a red flag. There is a slight footnote with that, which is that sometimes people with borderline personality disorder, also called emotionally unstable personality disorder, may state that they are going to do things that actually they have not so much intention to act upon. So you may have met these patients. They're quite common in Oxford, and there is a correlation between more sort of affluent group socioeconomic classes and seeing more of borderline personality disorder or emotionally unstable personality disorder. So it's something we see quite a lot of. Generally speaking, they are patients who will make you feel very strongly one way or another. You often either want to be these patients' saviors, or you want nothing else to do with these patients. They cause massive splitting, both in an individual and between a team. So if they're on a ward, they often cause splitting between the nursing staff as to how to care for them. I could do a whole separate presentation on borderline personality disorder, just to say that it's very difficult because patients with borderline personality disorder tend to present repeatedly with suicide attempts and self-harming, and it's very difficult to contain them because they will tell you they're going to do really dangerous things that often their history suggests they're not going to do. That said, there is still a 10% risk of death by suicide if you have borderline personality disorder. So even though these patients may be saying things that are untrue or that they feel are true, but we know objectively it's unlikely, their risk is real. And oftentimes it's actually counterproductive to admit them to a ward, just because then that provides them with a safety net, and their risky behaviour escalates and escalates and escalates. And we've had cases in Buckinghamshire, which is sort of just around the corner from Oxford, where several patients with emotionally unstable personality disorder took their lives on a ward because they sort of perceived that they could get away with more and more risky behaviour because there would be a nursing team there and a medical team there to save them. And very, very sadly, we didn't intervene in time and lives were lost. So that's very much a small footnote. The majority of people we see in A&E do not have emotionally unstable personality disorder, but it's just worth noting that is, if you're seeing someone who comes again and again and again, that might be something that needs thinking about. Like I said, there is no point saying someone is high risk of suicide or low risk of suicide. They've tried it, they've done multiple studies, it doesn't work. You just have to kind of assess it on a case-by-case basis. So if I'm doing a risk assessment or a risk summary for a patient, rather than saying high or low, I will sort of tell a story that kind of explains to somebody reading it why I'm worried. So for example, I might say Mr. X has made a recent serious attempt on his life by taking 100 paracetamol tablets in a locked hotel room, and was only discovered by chance when a friend noticed he had not returned to a conference the next day and alerted hotel staff. So that's really worrying, just because this is someone who's locked himself in a place that isn't his home. He's not got any friends or relatives around him, and he's taken a lot of paracetamol tablets. So there's this way of looking at risk, but the other sort of more psychodynamic model that's by Joyner, who's a psychologist, is this one, and I quite like this one. So it's a sort of Venn diagram. So there's an element of feeling alone, thwarted belongingness. So like they're widowed, they don't have a lot of social support, for example. And that overlaps sometimes, obviously that's one aspect. Another aspect is perceived burdenness. So I'm a burden. I'm a burden on my family. I keep having to ask for help. I'm a burden on healthcare workers, something like that. And where the two intersect, that's where we see this capability for where the two intersect is a desire for suicide, which is here. So wanting to be out of the way because you don't belong and you feel like you're a burden. And then where we see the serious attempts and near lethal attempts is here, where you have not only the I'm alone and I'm a burden, but the capability for suicide. Now, what I mean by that is this someone who's made multiple previous attempts? They know what dose of drug they need. They know how deep to cut. Are they a doctor? Are they a farmer or a nurse or a soldier? Somebody with access to means. All of those things sort of increase someone's capability to harm themselves seriously. So I'm just going to show you the assessment performer that we use in EDPS because I find it's quite a helpful way of setting things out to think about. Let's try and so that's just demographics when they presented. So we always ask, you know, are you happy for us to share information with your GP? Are you happy for us to talk to the person you've come with? We always try and get a collateral history from someone they've come with, because often patients don't tell you the whole story, often not on purpose, but often because they either, usually they underestimate how ill they've been. So that can be really helpful to get someone else's information. A brief sentence as to why someone's come to A&E, asking questions about their history, you know, how long has this been going on for, when did everything start, what's been the effect on their work or their role at home. And then we ask specifics about self-harm to try and really pinpoint that risk I was talking about. So when was it? What's been going on to prompt it? Were you alone in a locked room? Was anyone else at home? Did you call someone immediately afterwards? Or did you only let slip by accident that you'd taken that many tablets? Had you been drinking? Had you been watching anything that, or online or on TV that influenced you? So there was a Netflix series called 13 Reasons Why about teenage suicide that was thought to have caused a recent spike in teenagers harming themselves. And have they bought anything online to try and harm themselves again? There's then the Beck Suicide Intent Scale, which touches on a lot of the things we've talked about and that were covered by SAD persons. It's unfortunately copyrighted is the wrong word. There's a paywall to get to it, but if you Google it, that most of the time you can get a sort of people have summarized it, and there's a list of things. So it's things like was anyone nearby? Was there someone that you could contact? This is kind of the objective stuff. There's also the subjective. Did you think that what you'd done was lethal? Did you think that you would be recoverable with medical intervention? So it's trying to get an idea of how dangerous was this from the clinician's point of view, and how dangerous was this from the patient's point of view. The number doesn't really mean much, but it can be quite helpful just as to make you think, okay, maybe this patient is riskier than I thought, or maybe this patient thinks that what they've done was more risky than I think it is. Do they have any plans to repeat? And always screen for depression. So what's their appetite like? What's their sleep like? What's their libido like? That can be an awkward question. What's their concentration like? Are they still getting pleasure from doing the things they normally do? Are they still going out and socializing? Obviously at the moment that's not terribly relevant, but are they taking any medications at the moment? Has anything new been started? And then mental health history, also asking, what have you been on in the past? What worked? What didn't work? Did you have any bad reactions to anything? Because it might be that we're thinking about maybe starting them on something now, or writing to the GP and advising that they start them on something. Have they ever been admitted to a psychiatric hospital? And if so, was that under section or under the Mental Health Act, or were they an informal patient who could come and go as they pleased? Have they self-harmed before? Physical health history, so any conditions that they know of. We always try and talk to people about smoking as well and try and get them to quit, although often they're in far too fragile a state at the time to think about that. Family history, both mental illnesses and physical illnesses. Personal history, we do try and sort of go back all the way to childhood if we can, although the interview is only sort of 40 to 45 minutes long. People can give you kind of a brief summary of how they were at school. Did they have a supportive family growing up? Were they ever abused? Are they being bullied at the moment? Are they a serving soldier? And what is their current social life like? Where are they living? Who are they living with? What's the support like? Are there children at home? And if so, do they need to be looked after? Who's looking after them at the moment if a parent is with you now? Do social services need to be notified? Do we need to think about safeguarding if this child has no one else to look after them, or if they're being exposed to risky behaviour by the adult that's supposed to be caring for them? Have they had any problems with the police, or have they experienced any violence from anyone else, or have they been violent towards anybody else? Are they drinking? Are they taking any drugs? Third-party information, really useful. Like I said, if they've got someone who's come with them, do try and talk to them as well. Obviously, it's best at some point if you can talk to the patient on their own, because sometimes, for example, a 17-year-old is unlikely to tell you that they're smoking weed if their mum's come in with them. But it's also really helpful to talk to mum as well. Mental state examination I'll come to in a minute. Impression and formulation tends to be what we use rather than diagnosis. So because we're only seeing someone for a very brief snapshot in crisis, it's not really fair to label them with a diagnosis. I mean, it may be that it's barn door depression. They give you a history of weeks and weeks of feeling awful, and you are now seeing them at crisis point. However, more often than not, it's less clear cut. It might be that they've recently lost their job, or there's some kind of short-term stressor that's added to what was already going on, and often it's a little bit fuzzy. And so what we tend to do is provide a formulation, which is something that psychologists do all the time, instead of a diagnosis. So I might say, for example, Miss so-and-so is a 19-year-old who has had some time off school because she's been really struggling with her work despite being normally very academically gifted. During this time, her mood has spiraled downwards. She's been feeling lower, her appetite has reduced, but her sleep has been normal. She's still managing to socialise with friends, but this evening she had a very impulsive urge to take a bottle of paracetamol. She has no plans to repeat this, and is going to try and be more open with her mum and her school about how she is feeling, for example. So it's just kind of a few sentences that summarise what's been going on, what this patient looks like, so that when the GP reads this letter, they're like, okay, I know what's going on. Risk summary, we've spoken a little bit about. So risk of neglect is sometimes if patients are really depressed or if they have dementia, they might fail to look after themselves very well. Safeguarding we've spoken about, and then we have a plan. So that's what we have for our assessment. Oops. And then mental state examination is hopefully where the next recording starts. So I'm going to stop there, and hopefully this will work. So the mental state examination is the examination in psychiatry. We do physical exams on patients, but they tend to be the ones that have already been admitted to us. The patients we see in A&E, this is our examination for them. So no stethoscope required. So the first thing we want to know about is their appearance. How do they look? What are they wearing? Are they wearing something strange like this gentleman? Have they put on a lot of makeup that isn't usual for them? Sort of anything like that. Do they look older than their actual age, or vice versa? Their behavior. So usually I comment on eye contact, rapport. Are they friendly? Are they fidgeting? Are they doing anything odd? So eye contact wise, it might be very normal. Sometimes people won't look at you. They'll just look at the floor continually. That can also be disconcerting. And sometimes people are looking at you really aggressively, especially if they're agitated. How are they making you feel? Do you feel that they're about to, like this jaguar, pounce? What's their speech like? So tone, rate and volume are the things that I usually comment on. So are they aggressive in their tone? Are they quite apathetic in their tone? Is it monotonous? Are they speaking really loud or very quietly? Are they speaking so fast it's really hard to understand because they've got pressure of speech? Or are they talking really slowly because they've got psychomotor retardation, like in depression? And then their mood, and there are two aspects to this. There's objective, which is what mood you see, and there's subjective, what mood is the patient experiencing? For example, you may have a patient who tells you that they want to die, but actually while you're talking to them, they seem okay, they're laughing, they're joking. There's something that doesn't quite fit, and that does tend to be patients with borderline personality disorder, where they actually sort of seem fine, but they're telling you they're riskier than they are. And sometimes in psychosis, you'll see people with what's called an incongruent affect, which is where they might be talking about the death of their mother who was very dear to them, but they'll be laughing. And that's not because they find it funny, it's just because they're ill. There's a miscommunication with the wiring, and they are displaying a mood that is not actually the mood that they're feeling. So thoughts, we talk about thought form and thought content. So thought form is where you come across things like, you may have heard the term loosening of associations. So that's where it's really hard to follow what a patient's train of thought is. So they'll be hopping from one topic to another, and it's very hard to see how they've made a connection. So when we talk to each other normally, you can see where a conversation's going, you can understand where you've got to, because I don't know, you were talking about your holiday, and then maybe you were talking about boats, and that's how you got to boats. Whereas with a patient with thought disorder, if they're manic, they might have flight of ideas, so they might have just loads of stuff they want to tell you about, and they're hopping from subject to subject. Or they might have clang associations, which is where they're sort of, I might say something like, oh, well, I was marking a paper the other day and I did really well. Well, there's about a well at the bottom of my garden, and it's, either rhyming words or same words that mean different things, but are the same words. That's how a patient's getting from one thing to another. And yes, Also thought content, so things that like delusions. So this is a cat that thinks it's a lion. It isn't, it's a cat. Somewhat reminiscent of, I don't know, there's this chap who's been in the news quite a lot recently called Donald Trump, who thinks that he's very good at everything and definitely isn't. You know, that sort of belief that that there's so much evidence that it's not true, but the patient still believes that it is true, and that's how you identify a delusion. People also have paranoid delusions where they think there's somebody after them or someone's going to harm them, and that can be really distressing. Perceptions relates to, are they hallucinating? And hallucinations can be visual, they can be auditory, they're the two most common ones, but they can also be tactile. Generally speaking, a patient who is psychotic will not tell you that they are hearing voices. Generally speaking, a patient that's a good question, Bashar, and I will come back to it. So if someone is psychotic, usually what will happen, and they're hallucinating, is that while you are talking to them, they will be constantly distracted or looking over to somewhere else in the room where there isn't anybody. I once had a patient who was talking to an empty chair and addressing it as Jesus, and was having a conversation with him, then turning back to me and continuing our conversation. So that's usually how a psychotic patient will present with hearing voices. If a patient doesn't seem distracted or distressed and tells you they're hearing voices, usually they're experiencing what we call pseudo hallucinations. And this is kind of like, the best way I found of thinking about it is it's like somewhere between a hallucination and your own inner monologue. Most people have an inner monologue, you know, I'm thinking about what I'm going to say. It's a voice inside someone's head that, and again, often this is in people with personality disorder, you see this, but also you sometimes see it in people who are recovering from a psychosis, that they recognize isn't really there. It's not somebody talking to them like someone who's psychotic might experience. It's an inner feeling. Cognition is something else we assess. So if it's an elderly patient, you might want to do a Montreal cognitive assessment, a MOCA, or a mini mental state examination. And the clock drawing test is the test of executive function that we often use. And then insight. Does the patient realize that they're ill, that they have an illness, and are they accepting of treatment? So most patients with psychosis and mania, they don't think there's anything wrong with them, and they think that you're trying to label them as mad when they're not mad at all. They're absolutely fine. Whereas people with things like depression, anxiety are usually much better at recognizing, no, I'm not well, I really need some help. So yes, this comes back to your point, Bashar. Yeah. So if a patient's not talking about suicide, where does it fit in? So if I'm talking to a patient about depression, a low mood, or even anxiety, because anxiety and low mood are so interconnected, I will always ask, and it's not the easiest thing to do at all. And it's taken me time to develop. I now kind of have a patter of what I say. So even if someone has come with self-harm to A&E, these things are still important, you know, even if it is obvious that this is what you're going to be talking about. Somewhere private, being on the same level as the patient. I know it sounds silly, but I think it makes a huge difference. You don't want to be standing over somebody in a hospital bed. That's why I included the picture. You know, if your patient's on the floor, sit on the floor with them. Empathy. I mean, you know this, you're medical students, you know, you've gone into this job because you want to care for people. But just letting the patient know that you are empathetic, you know, saying something like, that sounds really hard, I'm really sorry to hear that, can be really helpful. And as I was saying before, you know, when you have suicidal ideation and depression, it can be really distressing. You know, thinking about that repeatedly can be very upsetting for people, especially if they've not experienced it before. So sometimes normalizing that, saying, you know, when people are feeling really down like you are at the moment, sometimes they have thoughts of harming themselves. Is that something that you've had? And often that will be your way into talking to people about it. And then I think the other important thing to do at the end of talking about suicide is to kind of find the hope at the end of the tunnel. So trying to identify what's their protective factors, you know, have they got children, have they got a pet, Have they got a family or a job that they really enjoy? What was it that stopped them if they didn't make a serious attempt? What was it that stopped them? Obviously, it's a little bit harder if someone really has made a very lethal attempt on their life, and then you need to sort of more proactively probe what is their good going on. And it might be if they're really depressed, they can't identify anything, and that's a patient you really need to worry about. So these are just a couple of the things that I say. I think everybody finds their own way of talking about it. But the first one, like I said, it's trying to normalize, you know, when you have low mood, you can sometimes think about these things. Is it something you've had? You know, can I ask why you took those tablets? I know it's not easy to think about, but did a part of you want to die? People can be quite cagey about that sort of thing. Some people will come straight out and say it, but a lot of people, it's really hard to talk about. And another question to ask your patient is, do you think you're going to be able to keep yourself safe when you go home? And I guess a lot of what we do in that very short time we have with our patients in A&E, because it's usually only an hour and a half, which I know seems long compared to other specialties, but for us isn't very long, is making a safety plan with them, you know, figuring out who is important in their lives, who can be supportive. Does their friend need to come and stay with them for a bit? Do they need to go and see their GP over the next few days and maybe think about starting an antidepressant? So that's a question that's quite important in terms of safety planning, which is fortunately what the next slide is about. So this is the safety plan that we use. Oops. And it's just quite nice for a patient to have something written down to take away with them. They don't have to share it with anybody if they don't want to, but it just means that they've got some evidence of how they were feeling and are sort of validated in what they've been through. So this is one I did with a patient the other day. He was having some suicidal ideation. He had a lot of stuff going on all at once, but we actually identified that his mum's very supportive. He gets on really well with his GP. Turning Point is our drug and alcohol addiction service that we have, and he had a key worker with them who he got on really well with. And then just a plan. And so things like, you know, trying to distract yourself because he was ruminating a lot. Practical things for this guy were like contacting his solicitor to find out what's going on with the legal case he's involved with. Bereavement counselling we're very lucky to have a charity for that in Oxford. And then there's, on every plan, there's this chunk at the bottom, which is just free phone numbers that we have in the UK to call for support. And there's, I'll send this across to you, because also there's some websites here that anybody can access. And also some, on the left-hand side, some sort of useful things to think about. So a crisis toolkit is what we sometimes advise people to have, something to distract themselves with, like I was saying before, something to do instead of self-harming. And then another thing that I often try and ask patients to do, although I'm not sure it's on here, is to, what would you say to your best friend if they were feeling the way you were? And people are often much kinder to a friend than they are to themselves. People often beat themselves up, and this is just anybody, not necessarily people with mental illnesses. We're much nicer to other people than we are to ourselves, generally speaking. So yeah, what would you say to a friend feeling this way can sometimes be a really helpful tool. So what about the agitated patient? Sorry, I've ruined the surprise now. Number one is your safety. That might mean going with security. That might mean waiting for them to calm down. That might be waiting for the medics to give them a bit of lorazepam or a benzodiazepine just so they're a bit calmer, because if you can't keep yourself safe, you're not going to be able to keep the patient safe. The other thing to think about is if you've got a room you can see them in with two doors, that can be quite useful, because it means that you've got two potential escape routes and they can't block both doors at once if you do need to leave and you think they're going to be violent or you think they're going to be trying to get up in your face. De-escalation. You've probably come across this in medicine before, because we've all met angry patients in every branch of medicine, but it's that sort of trying to listen and talk very calmly, trying to talk people down, saying that you hear what they're saying, you hear the complaint, and you're here to try and help. Worst case scenario, that doesn't work in A&E. What we tend to do is offer them some lorazepam. If they're so agitated that they can't even accept oral medication, sometimes we have to use rapid tranquilization. And that would be under the Mental Capacity Act. So This can be used by any doctor, and it enables us to treat people in their best interests when they don't have the ability to retain, understand, weigh up information about their treatment. So if someone's intoxicated, if someone's psychotic. If someone is intoxicated, you can't interview them. There's no point trying to talk to someone who's taken a load of benzodiazepines, a load of alcohol. They're not going to be able to give you an accurate history of what's been going on, and they may fall asleep halfway through, which has happened to me before, and it's not very fruitful. So just wait for it to get out of their system, and the medics can look after them until we come and see them, and then eventually you'll get onto your history examination and your differentials. So for the agitated patients, we don't often deal with this, but I think it's very worth mentioning. Oh, sorry, you mean interview for mental capacity? So usually, because the medics see our patients before we do, yeah, there are 4 components to mental capacity. So there's being able to understand information given to them, retain it, so remember it, weigh up the pros and cons, and then communicate a decision. And if a patient can't do any one of those 4, they don't have capacity. And it's worth saying that communication, you can aid it in any way. So it might be someone can't talk, but they can sign or they can write down their decision. So if they are failing any of those 4 points, you can treat them in their best interest under the Mental Capacity Act in the UK. I'm not sure how it works your neck of the woods, but we can have a chat about that at the end. So yeah, just one I wanted to mention in terms of intoxication and withdrawal is delirium tremens, just because it does have a 10 to 15% mortality rate. So your patient's going to be very sweaty, very agitated. They're going to have autonomic disturbance. And the reason I've included this picture of Gulliver from Gulliver's Travels is that people often hallucinate small people or small animals. And they're very sweaty as well, like this gentleman, although in fairness to him, I think he's just done a workout. But and the important thing to remember in anybody withdrawing from alcohol is Pabrinex or vitamin B1, because it's if you don't give it to them, they're going to develop Wernicke's encephalopathy, and if they still don't get it, they're going to develop Korsakoff syndrome, which is where people can't form short-term memories. Like I said, that's usually the medic's problem, but we always keep it in mind because it can develop 48 to 72 hours after drinking. So there is the potential for someone to be admitted to a psychiatric hospital who'd been drinking heavily and then develop delirium tremens. So psychosis, I mean, I always think this is the more exciting thing to see in A&E, but it's probably because we just don't see it that much. So history is key. If a patient's really psychotic, they're not going to be able to give you a history, so you're going to have to rely on that from friends and family. Family history, like I said, is important because there is a genetic component. Features of the mental state examination. Anyone want to contribute what you might see in the mental state examination in someone who's psychotic? Yes, absolutely. Hallucination, delusional thoughts, excellent, yes. So yeah, exactly what we were talking about before. So let me just try and get there we go. So I've seen several walls like this in the past. So this is somebody who's obviously got yes, delusional thoughts, speech disorders. So yeah, I would call it thought disorder because usually it seems their speech is all over the place. But yeah, it's the delusional thinking and the thought processes that are all over the place. So yeah, their speech may be strange because at the extreme of thought disorder, people develop what's called word salad, where even the connection between words is lost. People aren't speaking in sentences anymore. So yeah, formal thought disorder. And then I was just going to mention as well, delusion-wise, there's Schneider's first-rank symptoms of schizophrenia, which you may have heard of. So those include thought broadcast, where people believe that other people can hear their thoughts, thought insertion, where they think thoughts are being put into their head, and thought withdrawal, where they think thoughts are being taken out. And sometimes you see people have thought block where they stop mid-sentence because they feel like someone's just taken something out of their head. They don't know where that thought was going anymore. I always specifically ask about these because people tend to not be very forthcoming about experiencing them. So those three things, thought broadcast, thought insertion, and thought withdrawal, I would always ask specifically about. And you can even preface it with, this is going to sound really strange, but can I just ask if you've ever experienced blah? And most people will say no. But occasionally you'll catch someone who says, oh, actually, yeah, I have been thinking that, who would have otherwise not told you. Yeah, hallucinations, Jemana, absolutely. So, you know, are they really distracted whilst you're trying to talk to them because they're hearing other things that you can't hear? And yeah, so like I said, it might be someone who's already got a diagnosis. It might be a first presentation. If it's a first presentation, you might be wondering, is it drug induced? And so I've just included here cannabis, cocaine, alcohol. All of them have the potential to induce psychosis. And there are certain studies that suggest that, much like with cancer, where it's kind of a multi-hit system, you know, there's the genetic predisposition, there's the environmental factors, there's the smoking or alcohol that all contributes. There's thought to be a similar pattern with psychosis. There's a genetic predisposition we all have, but then it's the environment we're exposed to, it's the social structure around us, it's are we subject to discrimination, what's the mental strain we're going through. All those things combine to produce whether or not we develop a psychosis. Management wise, it's probably beyond the scope of this lecture, but just to say that, you know, short term, we'd probably start something like olanzapine, which is a second generation antipsychotic. And then very rarely we see catatonia, which is where people with psychosis, they don't move, they don't speak, they've got negativism, which is a word I can never say. And like I said, we don't see it very often, but that we manage with IV lorazepam. So delirium or dementia, I promised I would get to it. So you've got an elderly patient who seems very confused and agitated. It can be really hard to know just by looking at someone what the heck's going on. So, I mean, the responsibility largely lies with the medics to figure out if someone's got a delirium or not, because all of their examinations and investigations should show whether someone's got an infection, like a UTI, a chest infection. Abdo exam is important because being in urinary retention or having constipation can also cause delirium. Are they on a medication that's causing them to be delirious? You know, particularly, I guess it's been in the news more recently, is, you know, steroids can cause delirium, they can cause mania, they can cause psychosis. However, if the medics can't find a cause, the answer to your question, is it delirium or dementia, is going to be in the history. And it's going to be the history from someone who is not the patient, because patients with delirium or dementia are not going to be able to give you an accurate history. So was it a quick onset over the past few hours or days? It's delirium. Or is this a gradual decline over the past few weeks and months? It's more likely to be dementia. Confusingly, you often see in old people delirium on top of a dementia. Now, it'd be very rare for them to first present to you in A&E with that. But in that case, you would see a gradual decline over the past few months and then a sudden acute worsening. You see it a lot in patients who are already known to have dementia, especially if they get something like a UTI, but it's just worth mentioning that you can have both. You might want to ask about their past medical history. What's their cardiovascular risk like? Could this be a vascular dementia? Do they have Parkinson's disease? Do we think that this is dementia with Parkinson's disease or Lewy body dementia? Interestingly, cardiovascular risk factors, although for a long time we've recognized there are risks for vascular dementia, more recently we're identifying that actually there are risk factors for Alzheimer's as well. And then also family history. So all of us have a 1 in 20 chance of developing Alzheimer's at some point. I know, it's really depressing. However, if someone has a first degree relative who had Alzheimer's, that risk increases to somewhere between 1 in 8 and 1 in 6. And I say that as somebody who has Alzheimer's in the family, so I know I've got fun stuff to look forward to. It's all good. So yeah, and the other thing worth asking about is alcohol history. And again, a patient might not give you an honest answer. You guys probably know that people tend to massively underestimate how much they're drinking. But if they've been a chronic drinker, you know, there's a risk that they might have alcohol-induced dementia, and people who've drunk heavily for their whole life can develop alcohol dementia. Management of delirium. Treat the underlying cause. It's usually antibiotics, or it's laxatives, or it's whatever the cause of the delirium. Let's fix it. Also maximize orientation. So what I mean by that is, have they got their glasses with them? Have they got their hearing aid? Is there a clock on the wall that they can see? Is the ward well labeled? Do people know that they're in a hospital ward? Because that's really helpful to help people know what's going on and be less confused. If people are still agitated, you can use benzodiazepines, but there's a risk of falling with that. So you kind of need to balance, is he so agitated we need to give him this, or is he a massive falls risk and he's osteoporotic, so he'll probably break his hip if he does fall. You can also use antipsychotics. You can use haloperidol and you can use risperidone. They're the main two I've seen used. However, you need to be really careful that someone hasn't got Parkinson's disease or Lewy body dementia underlying their delirium. Because if you give them an antipsychotic, you're going to make their Parkinson's or Lewy body dementia much, much worse. And also you're going to increase their risk of stroke. So using antipsychotics in elderly patients doubles their risk of stroke. Management of dementia. So different drugs, we use acetylcholinesterase inhibitors. So you might have heard of donepezil, rivastigmine, galantamine. They aren't great. At best, they give you a 3 to 6 month window of slowing down the process. So we still are way behind the curve with dementia and its management. We do not have good drugs for dementia. You can also, again, maximize orientation, let people know where they are. There have been some really interesting studies about pain and dementia. So I think it was in Sweden, they started giving patients with Alzheimer's just regular paracetamol. And for some people, it really improved their agitation. They became a lot more settled. And the thinking is that they were in pain, but not able to communicate that. This chart just shows the behavioral and psychological symptoms of dementia, which are often the most difficult for families to deal with. Often the memory loss is kind of much lower down their priority list than things like the aggression they might see, the suspiciousness, accusing people of stealing things, pacing and asking repetitive questions. And again, it's really hard to manage. You can use benzodiazepines, you can use antipsychotics, but the antipsychotics are only licensed for short-term use. And again, you're looking at the risk increase of falls and of stroke like you were before. So it really has to be a balance of pros and cons. The most important thing is to provide education and support for the people looking after them. So just so that they know that this is part of the dementia, what things are going to help the person, what things aren't going to help the person. Trying not to be critical, which can be really hard when you're being asked the same question 50 times a day. And carer support groups can be really helpful so that people can just share their experiences. I don't know if we've got time. Do you know what? I'm going to skip over this, but you can have the slides so you can come back. So this is emergencies caused by our drugs, which we will come back to another time. I'll send you the slides so that you can see it. But yeah, I want to make sure that there's time for a chat at the end. So thank you very much for listening. I'm just wondering, are there any questions or anything anyone wants to comment on? I'd also be really interested to hear what your experiences have been in Palestine, because I've read a bit, but that's not the same as being there and seeing your guys' patients. So yeah, it'd be really interesting to know.
Hi.
Hi.
Can you hear me?
I can, yeah.
Hi, this is Jomana.
Hi,
thank you for the lovely presentation. I had a question about, it's probably more of like an ethics question probably, but like if an intoxicated patient presents to A&E, like with an overdose or something, and they refuse any tests or treatment to be done, what do you do? Like, how long does assessing mental capacity take, or is it done in this case, or yeah?
Yeah, no, it's a really good question. So, and it's one that we often see. So often people will take paracetamol with alcohol. And so then they are, they're intoxicated, but we need to do the tests. So generally speaking, we try and de-escalate where we can. Obviously, that's not always possible. So there are the rare incidences where we do need to use the Mental Capacity Act to, for example, take blood under restraint, or to stop people from leaving the department. These are rare, often once it's been explained to people how dangerous the situation is, and once the alcohol or the effects of whatever drug it is they've taken start to wear off, they become more kind of compliant and wanting to get better. But there are rare incidences where, you know, we can see that a patient doesn't have the ability to weigh up the information we're giving them, and we do have to treat them in their best interest, because worst case scenario, if they were to die from that paracetamol overdose and we didn't know they needed treatment, having presented to A&E, they could then, their family could sue us for not treating them. So it's not easy. It's really not easy. And you know, as junior doctors, this would never be your decision. It would always be a registrar or consultant making that sort of decision.
Okay, thank you.
And that's a great question. After hearing all these depressing stories and seeing all this hardship, how do you cope with that kind of separate yourself from the job? I'm really sorry if I've thrown so many depressing stories at you. I think the thing is, actually, you can make a difference, even if it's just talking to somebody. It's giving someone to listen to them, and there are lots of people who don't have someone they can talk to and tell them how awful they've been feeling. And so I think, you know, even though we're not with people very long in A&E, it's very rarely I come away from a consultation thinking I've not made any difference to that person. There is nothing I've done to help. There's always, you know, somewhere I can point them in the direction of a website, or I can suggest they consider a certain medication that maybe they've not tried before. So I suppose I'm lucky in that, well, I guess we all are, in that, you know, as doctors, we can make that difference to people. And yeah, I'm waxing lyrical now, but you know, I think you guys are here for a reason. I mean, you guys must have seen some depressing stuff as well. I mean, why do palliative care doctors carry on? You know, all their patients die, but I suppose it's making that difference and feeling that you're helping. It keeps you going.
Great, thank you so much, Emma. And does anyone else have any more questions? I think we should give it just a few seconds if people are still typing.
Yes, yeah.
But thank you so much. But thank you so much for such an interesting and important talk. Actually, something that I think we don't always learn a lot about. Certainly not in my experience here in Oxford. We don't always have like it gone through like this. So thank you very much. Emma, do you have any other things to say?
I just wanted to say, you know, being a medical student is not easy. And if any of what I've been speaking about today resonates with you, please do talk to somebody. And whether that's, you know, dropping Rebecca an email, and, you know, I'm always happy to chat via email if any of you want to, because you've had a difficult time, or a friend or a family member, you know. That thing I was talking about, that feeling alone, it's such an important thing to break, and it's not easy to reach out sometimes, but you know, if you feel you need to, please do.